Welcome to Brain and Behavior. This is going to be a presentation on change in mental status. It's got a couple different names. This is often what you see when it was handwritten. You'll still see it, but now that computers fixing and changing the world, most people are typing out change in mental status. Another name for it is delirium. This is a psychiatry word. Metabolic encephalopathy, that's another word that's used. So change in mental status, delirium, metabolic encephalopathy, really interchangeable words. I've tried to sort of sort out when do you use which one. Not worth it. It's basically acute confusion. That's another word for it. I'm Kevin Overbeck. I am a associate professor at Rowan Geriatrics Department. I'm graduate 2003, family medicine, board certified, did my residency here, and then geriatrics fellowship here. Doesn't matter what type of doctor you're going to be. You're going to see delirium. You're going to be dealing with delirium. Hospital delirium ranges from 14 to 24% incidence in the hospital, up to 56%. I can tell you that's like half your patients. I mean, that's an unbelievable number. It's under-recognized, so it's probably even more common than this. It's just that it goes unnoticed. Intensive care unit, almost 80%. The surgeons are going to see it. Post-operative, 50%. But why do we care? Just because we're going to see it a lot, acute confusion. So we're going to see it a lot. We'll be experts. It goes under-recognized, so you might see it, decide that this is, what's expected. This is typical. The hospital mortality, right? Anywhere from a quarter, 1 out of 4, to 3 out of 4 patients will die. All right, it may be in the hospital, and in that 1 year mortality, you're approaching half your patients, at least 1/3, will die in the next year. So delirium is a problem. We like to prevent it, of course. There's some prevention strategies we'll go over, but super common problem. And also, it's telling you your patient's a bit weaker than maybe you otherwise thought if they're going to be at risk to die in the next year. So our learning objectives, the learner will be able to recognize the presentation of delirium. You're going to ask, well, what's it look like in a vignette so you can ace your boards? Learners will be able to rapidly evaluate a change in mental status. What's the bedside tools you do to rule out delirium? We'll start with the case. Miss Elaine is a 98-year-old widowed female who presents to the office for an evaluation of paranoia. The chief complaint is paranoia, and a son endorses that she thinks her aide can read her thoughts. So this is a 98-year-old that has a caregiver in her home, supporting her, making some meals for her, making sure she takes her medicines, doesn't miss it. And the son says at least she thinks the aide can read her thoughts. It only has an aide 3 hours every morning. So the aide arrives about 9, leaves at noon, makes breakfast, makes lunch, gets her day started. But it's up to the 98-year-old Miss Elaine to get herself to bed. She ambulates with a walker. I'll give you a second case. Mr. James is a 93-year-old male with psoriasis who presents to the office for an evaluation of multiple rashes. Lives in the same independent section. He doesn't have any private home health assistance, but he walks with a walker as well. On his physical exam, you see that there are venous stasis changes. Those are usually chronic in nature. Allergic dermatitis, rash on his chest and back. He has a rash on the extensor surfaces of just on his knees. And then you also see eczema patches on arms and thighs. There's no rash on the hands, wrists, but definitely on the arms and thighs. So there's like an eczema, there's psoriasis, which you already had, there's allergic type reaction, and venous stasis changes. So that's probably too many rashes for one person to have. How does delirium exist? Well, it coexists. Some of your patients that already have cognitive impairment at baseline, called dementia, are going to be at greatest risk to develop delirium. So if someone has dementia, they can get more confused than they're already confused. Their chronic confusion becomes worse, and that would be delirium. So there's a lot of overlap and depression. So you have to really think of sort of the 3 Ds, delirium, dementia, and depression, all in the context of normal aging. So this is a zoomed out view, very rare in medicine that we can say, got to be one of these 4 things. If a person has a chief complaint of memory loss, or was it sudden, well, that makes me think delirium. Is it sort of gradual over a course of years, and it's sort of now you're noticing it's sort of worse in the last year? That's dementia. Depression has a lot of features with memory problems as well, especially with older patients. And then normal aging. I want to be anything but casual about that. We have a man who's turning 102 this month. He is still publishing books, writing books. He didn't become an author till he's 83. So let's be cautious about the memory loss that occurs with normal aging. The older you are, the more at risk you are for some of this stuff. But many other conditions on the horizon, and age, you can think of it as maybe a disease. So we don't think of it that way yet, but maybe we should, because our body's changing. We're at risk for this stuff. The older you are, the more at risk you are for developing delirium. Delirium, this is from DSM-5 criteria, so I think this is where the board exam going to come right from this, and that is a disturbance in attention. And make sure you know the yellow, the disturbance of attention. It's so key. If you have problems with attention, key feature of delirium, and awareness, a reduced orientation to the environment. Was I with anybody delirious this week? One woman who was sort of developing delirium in a hospital that I saw this week, she's 101. There was a window, but it faced a wall and at the hospital, and she was in a bedroom, all by herself. Now, she was sort of complaining about that, whereas I feel like having a private room when you're sick in a hospital is like ideal. She thought it was sort of a negative. She had no one to talk to and felt, lonely and isolated, didn't know what was happening, how long she was going to be there. She said I was going to go crazy in there. I was telling my daughter, get me out of here. I felt like I was going to lose my mind. She's pretty sleepless the day after and 2 days after, but then settled back in. So I think she did develop a delirium when she was there. Develops over a short period of time, right? So I sent her to the hospital. She came to my office. She was not delirious when I sent her to the hospital. We called 911 right from our office, and she went. Happened in a period of a couple of days. Change from baseline, attention, awareness, and it fluctuates in severity with the course of the day. That fluctuation is really interesting. Mental status tends to fluctuate during a 24-hour period. So I remember one of my first cases of delirium. I was a brand new attending. Rounding at the hospital in Cherry Hill, and had seen a patient, was sort of getting ready for discharge either today or tomorrow, and sort of just waiting on the neurologist to give me permission to send him home. And the neurologist came in and rounded, and I asked him, I said, well, what'd you think about her going home? She looks pretty good. And he said, this is like 3 p.m, but I'd seen her like 9 in the morning. And he said, well, I don't think she can go home in any state that she's in, probably, rehab. She needs support. So if you feel like she's medically stable, then you can send her to rehab, but she's not ready to go home. I said, well, she's almost ready to go home. And he says, well, I mean, she, I had to shake her awake. Well, maybe she was just tired. So I went to go back and see her, and it was a very different person than I saw at 9 a.m. That's a real common theme, is that you'll round with the attending. You'll see the patient at 9:30, attending rounds at noon, and there's 2 completely different patients, even though it's the same patient. Someone totally different than you saw. So you'll see this delirium really common. We already saw the incidents. Now that you know it, what to look for. So that woman was delirious. Ultimately, we decided that the outcome was that she had seizures. She had a seizure, change of mental status, came to the hospital. Workup was negative. We didn't know it was a seizure. And I saw her well at 9:30 in the morning, and neurology comes in, and she's sort of lethargic. She's post-ictal. And she was post-ictal. So we were able to get that diagnosis sort of by seeing her more than just once a day. Evidence that a disturbance in a direct physiological consequence. So medical conditions, substance intoxication, withdrawal, exposure to a toxin, or multiple etiologies. So that's what delirium is. Deficit in attention happens over a short period of time, and there's a fluctuation over the course of a 24-hour period. And it's due to a physiologic disturbance. So substance intoxication can create a delirium. Much alcohol, opiate overdose, right? That could do it. Bad infections. And in the case of my patient, she was probably more vulnerable, a change from baseline, because she was already starting with a pretty low cognitive reserve. So you want to think about that when we're thinking about aging, is that there is a loss of reserve. And so the brain mass decreased by almost 10% from your 20s or 30s to the time you're 70 or 80. The mass is greatly reduced. And so there's less reserve. There's less ability to sort of cope with an insult and maintain homeostasis. And delirium, I think, in many ways is a sort of proof of that, sort of evidence that that cognitive reserve is not as deep as you thought it was. Confusion assessment method. This is a method for assessing delirium. Inouye, who is the one cited here in a 1990 article. This was the original. That's why I cited it, not the most recent, but the original. So Inouye, if you want to learn more about delirium, you can look up Inouye and click on the journal you heard of, New England Journal of Medicine. She'll be there. She basically took DSM-5, just put it on a chart, called it something different, called it CAM, which is an assessment method of how to assess delirium. So you really need 2 key features. You need an acute onset, so it has to happen relatively soon. I mean, they were at baseline a couple days ago, an hour ago. And then there's a sudden change from baseline, or a fluctuating course. Someone that's sort of having good hours and then bad hours, and inattention. Okay, you need to have both of those. And if you have both of those, you also need one more thing. You need disorganized thinking or altered level of consciousness. And so in order to diagnose delirium, if we're creating a vignette, expect your patient to have acute onset or fluctuating course, inattention, and disorganized thinking or altered level of consciousness. This is from the 3D CAM training manual. 2014, 3D CAM came out. It was just basically a guide for researchers. Go to the bedside and certify that this person's delirium meets the criteria in a more formal way. Click on that or search it. It's free. 14 pages, but I've summarized it here, the most important stuff. Acute onset or fluctuating course. Again, remember, look at that yellow. Interviewing family members or healthcare providers. You really got to interview other people to really gather this. Delirium is often someone else brings them to the healthcare provider, or there's a healthcare provider who's concerned. So nurses are calling you because they saw Mrs. Jones and they were with her, just like me at that case at 9:30 in the morning and talking with a neurologist at 3 p.m. The nurse is coming on and she's like, I was with this patient, yesterday and she wasn't like this. And, so that's sort of an acute onset. It'll come from healthcare providers or family members most often, the acute onset or fluctuating course story. Sometimes it's worthwhile to ask patients, during the past day, have you seen things that are not really there? You're reaching for a coffee cup and when you reach for it, it wasn't there. During the past day, did you think that you were not really here in the hospital, thinking that you were home? One man that I was taking care of was describing that he was in his New York home and not in his New Jersey home. The same in every way, except it was in New York, not in New Jersey. Have you ever felt confused at any time during the past day? Inattention. Now, this is really the most important. The whole presentation, in many ways, is sort of born here. This is the cornerstone of, what the healthcare provider must be able to do, must do at the bedside. And for me, doing tests of attention is the same as listening to the heart. And I'm not a cardiologist, but I listen to a lot of hearts, right? I'm pretty good at it. And I'm expecting everybody here to be good at testing for attention. Dr. Farmer's lecture on mental status and the neuro exam really leads off with the mental status exam. And one portion of it is attention. And her example of attention is world. Spell the word world forwards and backwards. Spelling it backwards is a good test of attention. This is other tests of attention. This comes from the 3D CAM training module manual. What you start out with is the digit span test. So the digit span test is basically asking someone to repeat a sequence of numbers that you give them in backwards order. For example, these will be my instructions to a patient. I'm going to give you some numbers, and I want you to give me those numbers back to me, but in backwards order. For example, I often do an example. 186, you would say 681. 732. Now I'm counting. Now I know they understand the instructions. And 732, 237. 4196, 6914. And so those are tests of attention, being able to give those numbers in backwards order. Other ones are days of the week. So can you give me the days of the week backwards, starting with Sunday? Next is months of the year. Can you give me the months of the year backwards, starting with December? So digit span test is a series of 3 unrelated numbers. So you wouldn't want to do 313. You would want to do 3 different numbers and then 4 different numbers backwards. If the patient can give me them 4 different backwards, not delirious. So that's been really my favorite test, is 4 digits backwards. If a person can do 4 digits backwards, they're usually not delirious. I'm not sure I've ever seen anyone who is delirious who can do 4 digits backwards. If you're a cardiologist, if you're a dermatologist and you want to do these tests, well, why not? If they do 4 digits backwards, they're not delirious, okay? And if you want to do more, days of the week, months of the year backwards. If a subject has impairment in any one of these tasks, inattention exists. So we're going back to this: acute onset or fluctuating course, inattention. So if they have an error in any of these areas, inattention exists. This woman, I was trying to figure out if she was delirious or not, and she's really bright, and she really struggled on months of the year backwards, but she got them all right without a single error or prompting. It did take her a while. She was really concentrated to do it. But I could tell you, if the TV was on, if the door was open, and I can have noise from the hallway, she would not have been able to do it. I really believe that. I don't know, because that would require an experiment, that you need a quiet environment to do these. Use the environment you have. Just take the time to turn off the TVs if you're in a hospital setting, and close the door. So disorganized thinking is, what's the year? Okay, what is the day of the week? And what type of place is this? And so that's really orientation questions. If a subject has any errors in any one of these tasks, then this organized thinking is present. So this comes from the 3D CAM training module, that asking orientation is enough for disorganized thinking. Altered levels of consciousness. So was the patient sleepy or stuporous or comatose? Did they show hypervigilance? So you have this normal alertness, and this is going back to Dr. Farmer's mental status exam lecture on January 12th. She said that testing for alertness. She said describing, sort of the context that you find that patient, whether they're engaged in a crossword puzzle or a maze, or they're reading a book, or asking the nurse appropriate questions about their medicines. Sort of a normal level of alertness versus the hypervigilant, which is too nervous, too scared, often very active, overactive, pacing, those types of things. They almost always get everybody's attention. It's the sleepy, stuporous, or comatose, and mainly the sleepy patient who's the good patient. So the 80 or 90-year-old is the good patient, the one who doesn't cause much trouble because they're spending most of their time sleeping, is the delirious patient. Got to watch out for them. So these are risk factors. So advanced age is on the first of the vulnerability factors. So just being older age makes you at risk for lots of many things, right? Having dementia, we mentioned that at the beginning, that puts you at increased risk. If you already have memory problems to begin with, it doesn't take much to push you into that delirium. And once you get the delirium, we saw what that told you about, so your 1 year mortality, that 1 out of 3 chance that you're not alive in a year. It's worth preventing if it's preventable. Sometimes not sending them to the hospital in the first place, right? If we can find a way to fix their problem a day earlier, or an outpatient workup where they can stay home. Something called hospital at home, and I would think that many of you will probably be involved in some type of project like that. Not during medical school, but in the next decade to come. Hospital at home, it's coming. So one of these things puts you at increased risk. Polypharmacy, being on multiple drugs, sensory impairment. That was my patient. Told you there was a 101-year-old who went to the hospital, and we sent her with hearing aids. The risk is she goes with her hearing aids and she loses them. And they're not covered by insurance, so they can cost $4,000, as much as $6,000. I mean, they really can be really expensive. She goes to the hospital, she's wearing a mask. Many people are losing these hearing aids by taking them off, and they're coming off and they don't notice. Or they fall and they can't see where they went. It's a risk. She's going to go to the hospital and have no hearing aids. But then if she goes to the hospital and she has no hearing aids, then we're going to be putting her in that risk factor for delirium, which she seemed to develop anyway. So hard to talk to her. She almost seemed like a demented person when she had hearing aids out. Of course she's not, but she's used to hearing. And she's used to responding and people talking. But when you're 101 and doctors come in and you don't have hearing aids in and your hearing is impaired, you don't really know what they're saying and you're not really answering the questions right. There's a lot of risk with that. So ultimately the decision was go with your hearing aids, take the risk, because it's really your dignity. And delirium lowers your risk of delirium. So even dehydration, history of substance abuse, immobility puts you at risk for this. On the other side, the things that precipitate it, the things that bring it on, is infection, metabolic disturbance, electrolyte disturbances, urinary or fecal incontinence. I remember being pretty proud of seeing this patient that I knew was delirious, because one day they were good and the next day they weren't, and they might have had some tenderness in that one spot. It's quite a while ago, but boy, the risk was so great sending him back to the hospital, and we were able to work that out outpatient and put a catheter in, and certainly back to baseline in a day, all outside the hospital. So this is high yield delirium, is the medications. So medications is going to be huge in your lifetime. Of course, your doctors, you're going to be using a lot of medicine, but it's going to be the judicious use of medication, whether just prescribe or de-prescribe. And so the chief complaint of that 101-year-old was, I can't sleep. I was just in the hospital and it was horrible. And why'd you send me there? And I'm home and I never want to go again, and no matter what. But I can't sleep, so give me something to sleep. And it was sort of tough love, like I will if you can't sleep, but I want you to try a couple more days. And she did sleep fine actually that night. But the risk was that I give her medicine to sleep. Who wants to argue with a 101-year-old? They're asking something of me. I want to provide it. First, do no harm. It's hard to say because sleeplessness, insomnia will precipitate a delirium too. So you're sort of stuck. But these are the medicines that increase the risk of developing delirium. And so if you see these medicines on a person's medication list, benzodiazepines, opiates, anticholinergic medicines, which is sort of a category unto itself. These are antimuscarinic medications that are used for overactive bladders. There's one SSRI that is anticholinergic called paroxetine. The others are not. So anticholinergics are sort of hidden among our usual medicines. Steroids, psychotropics, anticonvulsants, any sedatives, really any sleepers. So we're back to Miss Elaine, 98-year-old widowed female. We said she had a chief complaint of paranoia. Son thinks that her aides can read her thoughts. We did 3D. I mean, I'm not teaching you something just out of a book. This is something that I do every single day. She scored a perfect score on a 3D cam. She did her digit span, 3 digits backwards, 4 digits backwards. She did the days of the week backwards. She did the months of the year backwards. She doesn't have inattention. And so just from that point of view, if you don't have inattention, then you're not delirious. You got to have inattention in order to diagnose delirium. And so she's not delirious. Okay, this is sort of a new normal, where instead of looking for other causes, maybe it's pneumonia, maybe it's a bladder infection. No, it's not any of those things. It's not a metabolic cause. This is a problem, and it's not due to delirium is not due to a metabolic cause. Mr. James, the 93-year-old with multiple rashes, right? One rash is okay. Venous stasis is okay if he came in with, just that rash, because that's a chronic and happens slowly over time. And maybe even if he came in with psoriasis, that type of thing, in which we already know that he has, and then add on a rash. Okay, I could do with 3, but not 4. Allergic rash and eczema. I mean, this seems like a guy's not getting enough care, and something's getting mixed up. He did not do well on his 3D cam. In fact, I was very worried about him because it was such a dramatic change from his baseline that he couldn't do really any of them. I think he got 3 digits backwards, but he couldn't do the months of the year, days of the week, or 4 digits for sure. He was diagnosed with delirium, and we put a plan in place to rapidly fix him up. Not just the rashes; they're easy to fix, but what's causing the delirium, and can we fix it?